All right, so the DSM-5 arrived. It's been out since 2013. And finally, we get to read from page 50, all the way to page 58. This will be 8 very long and painful pages. And what we're looking at, I'm looking at the diagnostic criteria for an autism spectrum disorder. And it is the code for billing the insurance is 299.00. And the ICD code for international and well-being markers is F84.0. Okay, diagnostic criteria is A through E. So A, B, C, D, E, 5 different criteria. In category A, or criteria A, you have the persistent deficits in social communication and social interaction across phone interruption. Again, diagnostic criteria starting with category A. Persistent deficits in social communication and social interaction across multiple contexts as manifested by all of the following, currently or by history, meaning what we know right now or what we know historically, what the patient has explained. And there are some examples. Examples below are illustrative, not exhaustive. See text. Okay. So under A, the persistent deficits in social communication and social interaction, we have 3, okay? First one is deficits in social emotional reciprocity, ranging, for example, from abnormal social approach and failure of normal back and forth conversation, semicolon, to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. That's all under A1. Deficits in social emotional reciprocity. Now, A2 is deficits in nonverbal communicative behaviors used for social reaction, ranging from, for example, from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures, to a total lack of facial expressions and nonverbal communication. Okay, we're already laughing, and we're only up to diagnostic criteria A. The last one is number 3. Number 3 is deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends. No absence of interest in peers. Well, that's because T-Rex is my friend, okay? T-Rex and fractals, yeah, they're my friends, and I am sharing imaginative play with them. All right, so we finished with diagnostic criteria A, persistent deficits in social communication and social interaction, such as number 1, deficits in social emotional reciprocity, 2, deficits in nonverbal communication behaviors, and 3, deficits in developing, maintaining, and understanding relationships. Fine, moving along. Believe it or not, under each criteria, the bold also indicates how to measure severity. So for the social communication category, the severity is based on social communication impairments and restricted repetitive patterns of behavior. See table 2. Well, table 2 says that the severity levels for an autism spectrum disorder are broken down in this table. And here we have column 1, severity level, paired by social communication, followed by restrictive repetitive behavior. So for every severity level, we have a type of social communication deficit, followed by the repetitive restrictive behaviors associating to that severity. We're not going to go into it until we get to it. Crossing that bridge later. Okay, so diagnostic criteria B is B out of E, right? So we're 2 out of 5. B is restricted repetitive behaviors, restricted repetitive patterns of behavior, interests or activities as manifested by at least 2 of the following, currently or by history, right? Currently meaning what we can observe right now as clinicians, and by history, what the patient has a history of. So examples are illustrative, not exhaustive. See text. Yeah, same thing like they said for A. So here we have 4, B1, B2, B3, B4. So B is restrictive, repetitive patterns of behavior and interest. So 1 of B is stereotyped or repetitive motor movements, use of objects or speech, for example, simple motor stereotypes, lining up toys or flipping objects, echolalia, idiosyncratic phrases. You get a car! You get a car! Okay. B2, insistence on sameness, inflexible adherences to routines, or ritualized patterns of verbal or nonverbal behavior. Yeah, I'm ritualistically professional. You can rely on that for me. And I get agitated when people are not professionals. Okay, so for example, extreme distress at small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, need to take same route or eat same food every day. Okay, isn't that like 80% of the normal people? Okay, so that's B2. We're going into B3 about the behaviors, right? Okay, so B3, highly restricted, fixated interests that are abnormal in intensity or focus, right? Because if it's restrictive, it's not abnormal enough. It has to also be restrictive and abnormal. Okay, Tanya, you're right. Stereotypies means stims. Ha! Okay, so number 3, we have an example of highly restricted and fixated interests are strong attachment to or preoccupation with unusual objects, excessively circumscribed, please be circumscribed, or perseverative interests. Hi, lab rat. Let me show you my lab rat. He lives here. Yeah. It's a prank. It's Revenge of the Nerds. Okay, so we have finally B4 is hyper or hypo-reactivity to sensory input, and I have no idea why this is under restricted behaviors and interests. Hyper or hypoactivity to sensory input or unusual interest in sensory aspect of the environment. So I'm unusually reactive to the environment. Oh, well, humans are also in the environment, sucks for me. For example, apparent indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. Okay, we finished the restrictive repetitive patterns of behavior, which is diagnostic criteria B. And again, severity is based on table 2. So now we go to diagnostic criteria C, the 3rd out of 5 choices we have, and we have to meet all of these, right, in order to be diagnosed. My t-shirt is lovely. Thank you, Tanya, for perseverating on meaningful objects. I really appreciate it. Tanya, yes, I don't know how to go live without mirroring the book, so yeah, we're coping, right? We're using our superior skills to be able to create mental imaging, be flexible, and find the alternative text in our minds. All right, diagnostic criteria C. Symptoms must be present in the early developmental period, but may not become fully manifest until social demands exceed limited capacities or may be masked by learned strategies in later life. They use masking. So for all of these people who ask, can I develop autism in adulthood, please refer to diagnostic criteria C, where the symptoms have always been present in early childhood. However, due to masking, you may not know about that until later. All right, that's a very short criteria. Look at that. It's a one-liner. Diagnostic C means that, yeah, I was always bullied, including my parents. They bullied me too. Yeah, okay, fine. By the way, Tanya, it's a dress. Okay. Diagnostic criteria D, 4 out of the 5, wait for it. Symptoms cause clinically significant impairments in social, occupational, or, not and, or other important areas of current functioning. That's the end of the one-liner. So if you find some kind of significant impairment in your social life, in your occupational life, or other important area, I don't know what an important area is, but I'm guessing difficulty using the self-checkout at the grocery store, very difficult. Okay, maybe I would meet criterion D. All right, we are on E, the last but not least of the 5 diagnostic criteria. So these disturbances are not better explained by intellectual disability, such as an intellectual developmental disorder or a global developmental delay, period. Intellectual disability and autism spectrum disorder frequently co-occur. To make comorbid diagnoses of autism spectrum disorder and intellectual disability, then in order for you to make these both, then social communication should be below that expected for general developmental level. Okay, so if my communication is less than expected for my age, I don't know, less or more or different? No, less. Meaning if I communicate like an 85-year-old with wisdom, then I'm not less than my developmental level. So, sorry. All right, note, individuals with a well-established DSM-4 diagnosis of autistic disorder, Asperger's disorder, or pervasive developmental disorder not otherwise specified should be given the diagnosis of autism spectrum disorder. Individuals who have marked deficits in social communication but whose symptoms do not otherwise meet criteria for autism spectrum disorder should be evaluated for social pragmatic communication disorder. And then it specifically tells the clinician, specify if with or without accompanying intellectual impairment, with or without accompanying language impairment, associated with a known medical or genetic condition or environmental factor. True in my case, I have 3 genetic conditions that are inherited that can have autistic behaviors. But of course, you know, they didn't do full exome sequencing until after my diagnosis. And then associated with another neurodevelopmental, mental, or behavioral disorder, for example, Fragile X, which is not an example they give, of course, because they're not capable of that. And then for coding note, it says use additional codes to identify the associated neurodevelopmental, mental, or behavioral disorders. And then finally, with catatonia, refer to the criteria for catatonia associated with another mental disorder. Remember that movie where we saw catatonic patients in a state hospital and then someone threw a baseball and they caught it in midair? Yeah. Catatonia is the only way to survive institutionalization and hospital delirium. Okay, finally, how to record these. Okay, we did the boring page 50 and 51. Now we're going to a bunch of monologues by people who don't know what the hell they're talking about. Okay, how to record these, right? Recording procedures. For autism spectrum disorder that is associated with a known medical or genetic condition or environmental factor, or with another neurodevelopmental, mental, or behavioral disorder, then you should record autism spectrum disorder associated with name of condition, disorder, or factor. For example, autism spectrum disorder associated with Rett syndrome. Severity should be recorded as level of support needed for each of the 2 psychopathological domains in Table 2. For example, requiring very substantial support for deficits in social communication and requiring substantial support for restrictive repetitive behaviors. I don't need support for my restricted repetitive behaviors. They're restrictive and repetitive all by myself without support. Specification of with accompanying intellectual impairment or without accompanying intellectual impairment should be recorded next. So if you have an autism spectrum diagnosis and you have a report and they did not indicate severity, they failed you, according to the Bible. And then finally, if catatonia is present, record separately. Catatonia associated with autism spectrum disorder. People who tend to get a catatonia associated comorbidity are people who are dunked in a bath and they don't react, like hot or cold. Yes. L-DOPA, yeah, exactly. Okay, specifiers. Now let's look at the specifiers. The specifiers, the severity specifiers from Table 2 may be used to describe succinctly the current symptomatology, which might fall below level 1, with the recognition that severity may vary by context and fluctuate over time. You see, sorry. From here we know that because it fluctuates, severity level is not hard-coded, right? Because it depends on how much support you receive. So if you get support, you don't Tanya's enjoying herself. Okay, let's not keep delving into distractions because that's hilarious, and we're making too much fun of something that people take very seriously. Let's not have too much fun. That would be illegal. Autistic people having a party. What is this? What is this? Why do we give them PhDs? For what? Okay, so with regarding the specifier about with or without accompanying intellectual impairment, understanding that often uneven intellectual profile. I have an uneven intellectual profile of a child or adult with autism spectrum disorder is necessary for interpreting diagnostic features. There are diagnostic features that I have, in addition to the nose, the noise hole in my face, and the, seizure balls in my sockets. Anyway, separate estimates of verbal and nonverbal skills are necessary. So you have to estimate my verbal and nonverbal skills? I don't know. The diagnostician didn't do that. They sent me to the speech therapy to do that. Okay, for example, using untimed nonverbal tests to assess potential strengths in individuals with limited language. Now, I'm going to warn you all adults, when you're going to make an appointment to your clinician, the very first thing you need to notice is that they are going to set the time for 11 o'clock a.m. for your appointment, and then the day before, usually 4 p.m., they will email you and let you know that the appointment is pushed off for 12 p.m. And this is one of the ways to start the assessment to see how you will react to a change in schedule and routine. Okay? I'm warning you. Know that. Don't take the bait. Page 53. We're still part of the specifiers. What else you need to specify in addition to saying, hey, they're autistic? So to use the specifier called with or without accompanying language impairment, then the current level of verbal functioning should be assessed and described. So if I got an autism diagnosis and then they also specify that I have an accompanying language impairment, but then they also need to describe the features and the severity levels. Examples of the specific descriptors for with accompanying language impairment might include no intelligible speech, nonverbal in parentheses, single words only. So if they can't intellectualize the words that I speak, then that's called nonverbal, right? Even though it's intelligible to me. Okay, single words only. Yes, no. You asked me a yes or no question. You want me to answer a pedantic monologue. Okay, sure. Hey, we got a code for that. Or phrase speech. Phrase speech is basically, you're asking me a question. Hey, how are you today? And I say, blue skies, smiling at me, nothing but blue skies. Do I see? Language level in individuals without accompanying language impairment may be further described by speaks in full sentences or has fluent speech. Since receptive language may lag behind expressive language, meaning their language that I receive from the neurotypicals may be behind what I express back to them, receptive and expressive language skills should be considered separately. I agree. However, receptive language is very much impacted by hearing impairment, auditory processing, none of which they look at. Raise your hand if you're autistic and they administered a hearing test ever in your life, in your adult life. No, we're never considered for that. Exactly. Lots of likes. You should like. All right. Additional neurodevelopment. We're on the last part of the specifiers. Yes, specifiers. See, executive function. Photographic memory. Additional neurodevelopmental, mental, or behavioral conditions should also be noted. For example, attention deficit, hyperactivity disorder, developmental coordination disorder. Developmental coordination disorder? Why don't you just call it dyspraxia like normal people? Okay, disruptive behavior. Impulse control. Or conduct disorders. That's a minus on your conduct report. Anxiety, depressive or bipolar disorders, tics or Tourette's disorders, self-injury, feeding, elimination, or sleep disorders. Okay, this is really important. If a person has an accompanying specifier, such as self-injury, it must also be added to their report. However, it's not part of the diagnostic criteria for autism, okay? Repeat, repeat, repeat. Self-injury, not part of an autism diagnosis. However, if self-injury is present, it must be added to the report for the protection of the client so that they can access resources for this co-occurring situation. We move on to backwards. Roll your eyeballs backwards so you can read it. There you go. Diagnostic features. Diagnostic features, we're up to page 53 out of 58. We can do this, we can do this, we can do this. Okay, diagnostic features. The essential features of autism spectrum disorder are persistent impairment. I'm gonna be late. You know what? Okay, yes, that's why my alarm rang, because I'm going to be late for a consultation that I have. So what we accomplished today is we looked at autism spectrum disorder 299.00. We looked at the diagnostic criteria A, B, C, D, E, page 50, 51, and then we started rambling all the way through the specifiers. I'm going to come back in an hour and we're going to continue. We're going to do diagnostic features, associated features, supporting diagnosis, prevalence, and then development and course. Oh, they can tell me the course of my lifespan, what's going to be like. Risk and prognostic factors, and then culture-related diagnostic issues, gender-related diagnostic issues, functional consequences of autism spectrum disorder, differential diagnosis, and then comorbidities like the last paragraph, right? So we are coming back to it. Count on me. Yes, Tanya, it's recorded. It's live on my page. Enjoy it. Have fun. My brain is beautiful. Finish.